let's talk about adrenal glands and neuroendocrine tumors now. Now, before I start this topic, I would just like to clarify that Bailey has included pancreatic endocrine tumors and men's syndrome in this chapter as well. But I have already covered men, that is multiple endocrine neoplasias, along with thyroid cancer. So if you want to look for men's syndrome, look for the module on thyroid cancers. And I've already covered pancreatic endocrine tumors in the malignant pancreatic module. So for these two topics, please refer to these modules. What I'll be discussing here are mainly adrenal tumors, and then I'll be talking about carcinoid tumors as well towards the end of the module. Now, the first thing which we need to discuss in this module is regarding adrenal incidentallomas. Adrenal incidentallomas. Now, with increased imaging and increased preventive health checkups, a lot of these adrenal incidentallomas are being picked up. In fact, in a lot of my breast cancer patients, when they undergo a PET scan to see if there's any distant metastasis or not, they are detected with these small adrenal lesions. And sometimes, we are in a fix whether they are malignancy, whether they're metastasis from breast or they're just adrenal incidentallomas. So we have to work these patients up properly and then manage them accordingly, which is what I'm going to cover here. Now, as I told you, adrenal incidentallomas, the majority of adrenal incidentallomas are non-functional. Majority of adrenal incidentallomas are non-functional, almost 75%. Another cause of adrenal incidentallomas, like I told you, can be metastasis. Now, metastasis, you can remember BLR, breast, lung, and RCC. This is the order in which they metastasize to the adrenal. Metastasis is approximately 2%. Cushing syndrome. Cushing producing can be 8%. And carcinoma, that is adrenal carcinoma, can also present as an incidentalloma in approximately 2%. Right? So these are the various causes of adrenal incidentallomas, the most common being non-functional tumors. You should remember the order in which metastasis also occurs to the adrenal glands. Now, as I told you, these are incidentally detected, so they'll be detected on imaging. Now, the first thing which we need to do is we have to rule out pheochromocytoma. We have to rule out pheochromocytoma because you know that an untreated pheochromocytoma can be catastrophic, right? Another thing which we need to do is to rule out a functional tumor. So the workup of this patient, when we come across a patient who has an adrenal incidentalloma, the workup would include all the hormonal assays to rule out a functional tumor and to rule out a pheochromocytoma. So you will do serum cortisol, plasma-free metanephrines for pheochromocytomas, serum DHEAS, dexamethasone suppression test, serum electrolytes to rule out a Conn syndrome as well, and urinary cortisol. So these are the tests which would be done in these patients to see if they have a functional tumor or not. Now, please remember another word of caution. Don't just blindly do an FNAC in an adrenal incidentallomas. FNAC should only be done if suspecting metastasis. But what is the thing which we need to be careful about? FNAC should be done only after ruling out which condition? Pheochromocytoma, correct. So we should rule out pheochromocytoma and then only do an FNAC, because if you do an FNAC in a patient with an untreated pheochromocytoma, that can trigger a huge release of catecholamines, and that can even lead to mortality. So please remember this. Now, how do we manage these patients once we've deciphered whether if it's truly an adrenal incidentaloma, and we find out whether it is a functional tumor or a non-functional tumor? Now, if it is a functional tumor, it should be managed. It should be managed accordingly. So, Cushing syndrome, Conn syndrome has all been covered in great detail by Dr. Rakesh in his medicine videos, so I'm skipping it in this module. If it's a functional tumor like Cushing, Conn's, it should be dealt accordingly, like he's told you. But if it's truly a non-functional tumor, and if the tumor is more than 4 centimeters in size according to Bailey, then the patient should undergo a lap adrenalectomy. But if the tumor is less than 4 centimeters in size, there is a case to manage these patients conservatively with observation, and every 3 to 6 months we will do an MRI. So every 3 to 6 months MRI surveillance is done for these patients. And when we are doing this MRI surveillance, what will be the indication to operate these patients? The indications for surgery will be if there's a more than 25% increase between two MRIs, more than 25% increase in size between 2 MRIs, or there is a suspicion for malignancy. That is when we'll operate an adrenal incidentaloma, which we've been managing by observation or surveillance. So this was regarding adrenal incidentalomas. This value of 4 centimeters has been asked in the exam, and you should know the main cancers which metastasize to the adrenal glands. The next topic which we need to talk about, before I talk about the next topic, you can see that this is a patient who had a scan, and this was an incidentally detected lesion. This is how adrenal incidentalomas are picked up. Now, the next topic which we need to discuss is a pheochromocytoma. That is very important for the exam. Lots of questions have been asked from pheochromocytoma in the exam. So you know that pheochromocytoma is a tumor of the chromaffin cells, arises from the adrenal medulla, and it is a catecholamine producing tumor, which majority of the cases they arise from the adrenal medulla. Majority are from adrenal medulla, and these tumors which arise from the adrenal medulla, they have equal male to female incidence. The extra-adrenal pheochromocytomas, if you have an extra-adrenal pheochromocytoma, that is known as a paraganglionoma. And these paraganglionomas, the most common site for paraganglionomas, is the organ of Zuckerkandl. This has also been asked in the exam. Now, this organ of Zuckerkandl is the sympathetic chain, the paravertebral sympathetic chain which is there. That is where these tumors can arise from. This is the organ of Zuckerkandl. And if you are asked the most common site in the parasympathetic chain, then in the parasympathetic chain, the most common site is going to be a carotid body tumor, or in the carotid body. So this you should know, that extraadrenal pheochromocytomas are known as paraganglionomas, and these are approximately 10%. Now, another thing which I want you to know, that Bailey still writes that there is a rule of 10, although Dr. Rakesh, I know, has told you that this rule of 10 is no longer applicable, but Bailey still writes that there is a rule of 10, so there is no harm in knowing about this rule of 10. 10% pheochromocytomas are malignant, 10% are familial, 10% occur in children, and 10% are extraadrenal. 10% are extra-adrenal. Now there is one modification which has happened in the latest edition of Robbins. So latest edition of Robbins says that there is a rule of 25 in familial. There's a rule of 25 in familial pheochromocytomas, and the rule of 25 says that 25% of these tumors have oncogenic mutations. 25% of these tumors have oncogenic mutations. Now I'll tell you which are the mutations which can be associated with familial syndromes and pheochromocytomas. But 25% of them have oncogenic mutations, and they occur at a younger age, and they can be malignant as well. They occur at a younger age, and there is a higher risk of them being malignant and bilateral. So one more rule of 10 is 10% are bilateral. Now, what are the various syndromes which can be associated with pheochromocytoma? That is another thing which has been asked in the exam. So the various syndromes associated with pheochromocytoma. Number one, you have MEN2 syndrome, and this is in fact the most common syndrome associated with pheochromocytoma. You should remember this, please. MEN2 syndrome is the most common syndrome associated with pheochromocytoma. Other syndromes are neurofibromatosis 1. Neurofibromatosis 1 is another one which can be associated with pheochromocytoma. Sturge-Weber syndrome. You have Sturge-Weber syndrome. VHL syndrome. We've covered VHL syndrome in the renal module when I spoke about renal carcinomas. Von Hippel-Lindau syndrome. And you also have familial paraganglionoma syndrome. So familial paraganglionoma syndrome, this familial paraganglionoma syndrome is due to mutation of succinyl dehydrogenase. Mutation of succinyl hydrogenase, SDH is succinyl dehydrogenase B and C gene. So SDH is succinyl dehydrogenase B and C gene. And this gives rise to paraganglionomas, which I've already told you are extra-adrenal. And because of these mutations, there is increased risk of malignancy. There is increased risk of malignancy. So these are the various syndromes which you need to remember for the exam as well. Now, metastasis. If metastasis is present, that is the only telltale sign that the lesion is malignant. Right? So the presence of metastasis only tells us whether the pheochromocytoma is malignant or it is benign. Although there are certain scores which can help in prediction of this as well, and one of the scores which has been mentioned in Bailey is the PAS score. So you should remember the name, the PAS score. This is pheochromocytoma. This is pheochromocytoma in adrenal scale score. Pheochromocytoma in adrenal scale score is the PAS score, and this takes into account Ki67 values. Ki67, I've already told you in breast cancer as well. This is a tumor proliferation marker. It tells me how quickly the tumor is dividing or proliferating. So higher the Ki67, more aggressive the tumor. And the other two things which it takes into account is vascular invasion and capsular invasion. Vascular invasion and capsular invasion. Now, before we talk about the clinical features of pheochromocytoma, what are the pathological features of pheochromocytoma? This you should remember. If you look at the gross specimen, and this has been covered by Dr. Illa as well, if you look at the gross specimen, you get a tan brown tumor. You get a tan brown tumor, and this tan brown tumor is due to a chromaffin reaction. This is due to chromaffin reaction that you get this tan brown tumor. There can be necrosis and hemorrhage present as well. So these are the gross findings. The microscopic findings. The microscopic findings, you can get the typical Zell-Ballen pattern. You can get the typical Zell-Ballen pattern. This has been covered in detail In pathology, this slide has also been asked in the exam. Or you can get salt and pepper nuclei. You can get salt and pepper nuclei. Right. Now, another thing which you need to remember, immunohistochemistry is important in pheochromocytomas, and these pheochromocytomas can be positive for synaptophysin, neuron-specific enolase, and chromogranin. Right, so these are the immunohistochemical findings which are there, and you should know these for the exam as well. Now, another question, and this is again a bit controversial because Dr. Rakesh has different views regarding this, but I am telling you what has been written in Bailey and standard surgery textbooks, and sometimes an MCQ has been asked regarding this. What are the various compounds which are released by different types of pheochromocytomas? Right, so if you have an adrenal pheochromocytoma, noradrenaline is more commonly released than adrenaline. Now, ultimately, this can get converted into adrenaline, but what has been written in the books is that first noradrenaline is released more commonly as compared to adrenaline. Now, paragangliomas release noradrenaline, and the reason why they release noradrenaline and they cannot release adrenaline is because these paragangliomas are deficient in phenylethanolamine N-methyltransferase. So they are deficient in this enzyme, because of which they cannot convert this noradrenaline into adrenaline, which is why paragangliomas, you need to remember, predominantly or almost all of the paragangliomas are going to release noradrenaline. If it is a malignant pheochromocytoma, then they release dopamine, and homovandalic acid. And if it is associated with Men's syndrome, then adrenaline release is more common than noradrenaline. So you should remember that these are the compounds which are released by pheochromocytomas, and sometimes a question has been asked regarding this as well. Now, if we talk about the clinical features of pheochromocytomas, so the clinical features would basically depend on this catecholamine release, and the typical clinical features which the patient presents with are headache, there can be sweating, and there can be tachycardia or palpitations. In these patients. Now, out of these, headache is the most common symptom which they have. If we talk about the signs of pheochromocytoma, when you examine such a patient, the most common sign which you will elicit is hypertension. That there is going to be hypertension in these patients because of the catecholamine release. They have hypertension. Now, hypertension in majority of the cases, it can be episodic hypertension. In majority of the cases, it is episodic. In a small frequency of patient, it can be continuous hypertension as well. And you need to know that these episodes of hypertension or these episodes of headache, sweating and palpitations can be triggered by multiple conditions, can be triggered by stress, can be triggered by trauma. So the patient would tell you that, when I'm going through a stressful period, I get these symptoms more commonly. So that is one of the things which you should keep into account. Also, one more thing is that a young patient coming with hypertension, right, and you can't find any other cause, there's no family history, the renal arteries and all are fine, that is another place where you should suspect a pheochromocytoma. Now, the investigations in these patients, how do we work up a patient with pheochromocytoma? So the screening test for patients with pheochromocytoma is urinary VMA, urinary vinyl mandelic acid or metanephrines. So this is 24-hour urinary VMA or metanephrines. This is the screening test. VMA is vinyl mandelic acid. You should know the full form. It's vinyl mandelic acid. So that is the screening test. The most sensitive test, this has also been asked in the exam. The most sensitive tests are plasma-free metanephrines. So this is the most sensitive test which can be done for pheochromocytoma. The imaging investigation. Imaging is very important because imaging is also suggestive of the pheochromocytomas. MRI is the investigation of choice, and you should know MRI is better than CECT. MRI is the investigation of choice. But if you have a patient who has an extra adrenal, pheo, or you're suspecting metastasis, then in those patients, and both me and Dr. Rakesh are agree to this point, that in these patients the investigation of choice is a gallium-69 dotatate scan. For these patients. So please remember this. For extra-adrenal pheo, and if you're suspecting metastasis, we do a gallium-69 dotatate scan. Now what exactly do we see in an MRI? On an MRI you will see light bulb sign. So this is the light bulb sign which we see on MRI. Some people like to call it the Swiss cheese appearance as well. You can also get a Swiss cheese appearance in this case. So this is how we work up. This is the imaging. Let's talk about the management of pheochromocytoma now. Now, one very important thing which you need to remember, that untreated pheochromocytomas can be catastrophic, especially if you take up a patient of untreated pheochromocytoma for surgery. There is a very, very high mortality rate, which is why if you remember when we were talking about MEN syndrome, especially MEN2 syndrome, I told you that before you operate the medullary thyroid cancer, always rule out a pheochromocytoma, because operating a patient with an untreated pheo can be catastrophic. Okay. So what you need to remember, that there is increased catecholamines in the system. So in these patients, we first have to give, first alpha blocker has to be given, and usually the alpha blocker is phenoxybenzamine. And we usually start with a 10 mg OD dose. We start with a 10 mg OD dose and keep on increasing the dose. Keep increasing the dose gradually. We keep increasing the dose gradually till the patient starts experiencing postural hypotension. Right? So when the patient starts experiencing postural hypotension, that is when we know that the patient is on adequate dose of alpha blockers, and at least for 7 to 10 days this should be given. It should be given at least for 7 to 10 days, right? Some people like to add a beta blocker. Beta blocker can be added. Beta blocker can be added if there is tachycardia present. If tachycardia is present, then a beta blocker can be added in these patients. Now, please remember, this is a very important question asked multiple times in the exam and in the Viva, that it is always alpha blockade followed by beta blockade. Never beta blockade first, because if you give a beta blocker first, there is going to be unopposed alpha action, more vasoconstriction, and that is going to take the BP very high, and that can also be catastrophic for the patient. So once this has been done, then the patient can undergo surgery. And laparoscopic adrenalectomy can be done for patients with pheochromocytoma. Laparoscopic adrenalectomy can be done for patients with pheochromocytoma, except if it's a large tumor. If it's a very large tumor, or we are suspecting if it's a malignant tumor. Or if you are suspecting if it's a malignant tumor. Now, one thing which you should remember, that there can be a sudden drop. There can be a sudden drop in BP when adrenal vein is clipped. When the adrenal vein is clipped. Right? Why will this happen? Because the body has become so used to living with such high catecholamine levels. As soon as you clip the adrenal vein, the amount of catecholamine drops. And this can unmask the dehydration in these patients as well. And because the catecholamines have also dropped, the BP can suddenly drop. So when we are clipping the adrenal vein, the patient needs to be given fluids, and sometimes they need to be given vasopressors as well to keep the BP high. Just a few words regarding metastatic pheochromocytomas as well. So malignant pheochromocytomas, I told you that metastasis will tell us if it's malignant or not, and the risk of metastasis increases with size. As the size increases, the risk of metastasis in these tumors also increases. We've already discussed that these are going to secrete dopamine and homovanillic acid, and metastasis is more common in bone, liver, lymph nodes. In this order, metastasis can occur in these patients. Now, the management of malignant pheochromocytoma is surgery followed by chemotherapy. And the chemotherapeutic agents given are dacarbazine and vincristine. Bailey also has specifically mentioned how to deal with pheochromocytoma during pregnancy. So this is a special situation of pheochromocytoma during pregnancy. And what Bailey has written is that if the patient is diagnosed in the first and the second trimester, it is written that you give alpha blockade, give alpha blockers, and operate after that. And you operate in the first or the second trimester. But if the patient is diagnosed in the third trimester, you give alpha blockers, and expedite the delivery and deliver a child, and followed by surgery. This is followed by surgery. So this is what you need to remember for pheochromocytoma in pregnancy. So that takes care of pheochromocytomas. I've told you the potential questions, MCQs, which have been asked in the exam from pheochromocytomas. Now the next condition which we need to talk about is adrenocortical carcinoma. Now adrenocortical carcinoma has a bimodal age distribution. So this has a bimodal age distribution. So it can be seen in children. This can be seen in children. And then the second spike is seen in the fourth or the fifth decade of life. The second spike is seen in the fourth or the fifth decade of life. So these adrenocortical cancers are more common in females as compared to males, and it is 1.5 to 1. That is the ratio of female to male incidence. And non-functional tumors are more common than functional adrenocortical carcinomas. Now this is a very important point to understand. I've told you non-functional are the most common. And Bailey clearly writes that these functional tumors are more aggressive. They have a poor prognosis, right? But one advantage of functional tumors is that they can be monitored easily. With whatever compound they are releasing, they can be monitored easily. right? So more aggressive, poor prognosis, but because of the functional compound which is being released, monitoring of these functional adrenocortical carcinomas becomes much easier. The clinical features of adrenocortical carcinomas, the patient is going to come with a lump, abdominal lump. There can be pain. Patient can come with Cushing syndrome, and this is the most common functional syndrome which can be there in patients with adrenocortical cancers. Cushing can be the most common functional syndrome in adrenocortical cancers. So that is how the patient can come. There can be metastasis as well. Metastasis can be to distant organs or can be to the lymph nodes, and metastasis is mainly determined, as I told you, by the size, capsular and vascular invasion. Capsular and vascular invasion will determine the size. The investigation of choice, like in pheochromocytomas, MRI is better than CECT. So MRI is the investigation of choice. It is a radiological diagnosis. And always, like we were doing in incidentalomas. Remember, in incidentaloma also I told you that one of the diagnoses for incidentaloma could be an adrenocortical cancer. So always rule out functional tumors. Always rule out a functional tumor. So do the same panel which I told you for adrenal incidentalomas. Electrolytes, DHEAS, cortisol, dexamethasone separation test, urinary VMA, all those tests would be done to rule out functional tumors when you're dealing with such a lesion as well. Now, the management of adrenal cortical carcinomas, unlike pheochromocytoma, where I told you that the surgery can be done by laparoscopic route, here we have to carry out open adrenalectomy. Here we have to carry out open adrenalectomy, and our aim should be R0 resection. Resect the entire tumor. That should be our aim. I've already told you R0 resection is microscopic freedom from disease. In addition to these, patients are going to get chemo as well. Chemotherapy can be mitotane. Ketoconazole can be used in these patients. Vincristine. Dacarbazine. These are the chemo agents which can be used in these patients of adrenocortical carcinomas. One final thing which you should remember in adrenocortical carcinomas, and this was asked in the NEET exam also 3 years back, is the Macfarlane's classification. Is the Macfarlane classification for adrenocortical carcinomas. So please remember the name. They did not ask the details. They just asked the name, but you should remember the details as well. It is not very difficult. Stage 1 Macfarlane is when the tumor is less than 5 centimeters. Stage 2 is when it is more than 5 centimeters. Stage 3 it is when it is locally invasive. When it is locally invasive. And stage 4 is when there are distant metastases present. So that is the Macfarlane classification for adrenocortical carcinomas. You should remember this for the exam as well. One more thing which you should remember is that etoposide and cisplatin can also be used as chemo agents in adrenocortical cancers. The next tumor which we need to discuss is a neuroblastoma. And if you remember the module where I was talking about renal tumors and I was talking about Wilms tumors, I told you that neuroblastomas are the most common abdominal malignancies in children. Right, so it's the most common abdominal malignancy in children. It's a malignant tumor. And it is the most common abdominal malignancy in children. Now, this tumor also arises from the adrenal medulla. So this tumor also arises from the adrenal medulla, and that is the most common site for neuroblastomas. But sometimes it can also arise from the sympathetic chain. From the paravertebral sympathetic chain also it can arise, but most common site is adrenal medulla. Now if we talk about the clinical features of neuroblastoma, Before the clinical features, you should know that it can either be sporadic or it can be familial. And familial ones are the ones which show ALK mutation. And these neuroblastomas, NMYC amplification can also be seen in these. NMYC amplification can also be seen in neuroblastomas. Now, if we talk about the clinical features of neuroblastomas, these neuroblastomas, the peak incidence is around 5 years of age. The peak incidence is 5 years of age. The most common presentation is an abdominal lump. The most common presentation of these patients is in the form of an abdominal lump. And I've told you that this abdominal lump, the characteristic of this abdominal lump is that it can cross the midline. It can cross the midline, and this can help in differentiating it from a Wilms tumor, which I told you usually does not cross the midline. It usually does not cross the midline. In addition to this, the patient can also have pain, and there are some peculiar metastatic features of neuroblastomas which you should know about. And one more thing which you should know is that almost 60 to 70% patients at diagnosis have metastasis. 60 to 70% patients at diagnosis have metastasis. But even if they have metastatic disease, we still treat them aggressively, because one more characteristic of neuroblastoma is that sometimes it can undergo spontaneous regression. Sometimes it can undergo spontaneous regression, which is why even if there are metastases, we will manage these patients aggressively. So one of the characteristic metastases which you can see in neuroblastoma are blueberry muffin lesions. These are skin metastases which are seen in these patients. In addition to this, these patients can also have raccoon eyes. We have discussed raccoon eyes when I was talking about head trauma, but you can even get raccoon eyes in patients with neuroblastoma. Another one is dancing eyes. Dancing eyes, this is opsoclonus myoclonus. This is also a typical feature which can be seen in neuroblastomas. In addition to this, there can be metastasis to the liver and lungs as well. Right, now how do we work up a patient with neuroblastomas, or what are the investigations which are done? So the investigation of choice again is MRI is better than CECT, but if metastasis is there, if metastasis is present, then MIBG scan is done. Then we do MIBG scan. MIBG is methioiodobenzyl guanidine scan. MIBG scan is done if metastases are suspected. Otherwise, MRI is the investigation of choice. Also remember that a bone marrow biopsy should be done in these patients for accurate staging. Bone marrow biopsy should be done for accurate staging. And always rule out a functional tumor. So we will measure cortisol. Cortisol, metanephrines have to be measured to rule out a functional tumor in these patients. So these would be the various investigations which we would like to do in these patients. Now the management of these patients. The management of these patients is surgery. And again, as we've discussed, we would try to achieve an R0 resection if we can. And chemotherapy can also be used in these patients. Chemotherapy is etoposide and cisplatin. Etoposide and cisplatin. That is the chemo which is given in these patients. And I've already told you that surgery will also be done if there are distant metastases also, because these patients, even with distant metastases, they tend to do well after treatment. Now there can be 3 risk categories for neuroblastomas. You can either have a low risk lesion, there can be a medium risk lesion, and there can be a high risk lesion of neuroblastomas. If it's a low risk lesion, the treatment is going to be surgery. Treatment is going to be surgery. and then we consider chemotherapy in these patients. We consider chemotherapy in these patients. If it's a medium risk, then we do surgery, and we definitely do chemo in these patients as well. If it's a high risk patient, then we do neoadjuvant chemotherapy. You know, neoadjuvant is when it is done before surgery, we shrink the tumor and then we carry out surgery in these patients. Now, a few words regarding the histopathology. When you resect the tumor, the histopathology of these tumors. These tumors can show intratumoral calcifications. And these intratumoral calcifications also show up when scans are being done, and that is another feature which helps in differentiating it from a Wilms tumor. Then Homer-Wright rosettes can be seen. Homer-Wright rosettes. This has been covered by Dr. Illa. And this is one of the small round blue cell tumors. This is one of the small round blue cell tumors. And like pheochromocytomas, the immunohistochemistry, they are also positive for synaptophysin. They also stain for synaptophysin and chromogranin. Right? So this was regarding neuroblastomas. Now coming to the final topic in this module, we need to talk about neuroendocrine tumors. Neuroendocrine tumors or carcinoid tumors. So we are talking about carcinoid tumors. Now these carcinoid tumors, you know, they arise from the argentafin or the Kuchlinsky cells. They arise from the argentafin or the Kuchlinsky cells. Now we are going to talk about these carcinoid tumors. Now before I talk about abdominal carcinoids in detail, I just want to share a table from Bailey regarding the distribution of carcinoid tumors. Now this is one of the most controversial topics because different books say different things. I know Harrison says something different, so Dr. Rakesh will teach you something else. I am going to cover what Bailey says, right? And then I leave the decision up to you because this is a controversial topic. So this is a table from the latest Bailey, and this clearly says that appendix is the most common site for these carcinoid or neuroendocrine tumors, 40%, followed by the small bowel, that is 25%, and this is usually the ileum. So appendix followed by ileum, and lung or pulmonary carcinoids are only 10%, rectum is 15%, right? So this is the table given in Bailey. Now we are going to talk about patients with abdominal carcinoids, right? So carcinoids, we can divide carcinoids into foregut carcinoids, midgut carcinoids, and hindgut carcinoids. Midgut and hindgut carcinoids behave in a similar manner, barring the fact that midgut carcinoids can sometimes show more metastasis as compared to hindgut carcinoids. So foregut carcinoids, we are going to consider bronchial carcinoids here, gastric carcinoids and pancreatic carcinoids. Midgut carcinoids will be your jejunal, ileal and appendicular carcinoids. Appendix, you know, is the most common site. Hindgut carcinoids will be your colonic and rectal carcinoids. Now let's first talk about these foregut carcinoids. Okay, so foregut carcinoids, let me give you an example. Foregut carcinoids are going to drain mainly into the systemic circulation. Okay, so if they're draining into the systemic circulation and if serotonin is being produced, then theoretically speaking, all this serotonin goes into the systemic circulation, right? If it's a bronchial carcinoid, all the serotonin is going to go into the systemic circulation. So theoretically, all patients with foregut carcinoids should develop carcinoid syndrome, but that does not happen. And why doesn't that happen? Because majority of foregut carcinoids are argentafin negative. That means they don't produce serotonin, right? serotonin is not produced. So if serotonin is not produced, they cannot produce features of carcinoid syndrome. So please remember this point. They can produce chromogranin, they can release chromogranin, which can be measured in the blood. So chromogranin A can be released and that can be measured in blood in these patients. Now these foregut carcinoids can show metastasis, and metastasis is most commonly seen in the bones. Foregut carcinoids, most commonly they will go to the bones. Now these midgut carcinoids on the other hand, appendicular, I've already told you, appendicular carcinoids are the most common. And these midgut carcinoids are going to drain into the portal circulation. They are going to drain into the portal circulation. So whatever serotonin is produced, serotonin is metabolized by the liver. So serotonin, they produce serotonin, they are argentophane positive, they produce serotonin, but all that is metabolized by the liver. So that is why they also usually don't give rise to carcinoid syndrome. When will they give rise to carcinoid syndrome? But if liver metastasis is present, then carcinoid syndrome can occur. Because now serotonin will leak out into the systemic circulation, and liver is the most common site for distant metastasis in midgut carcinoids. Now there is again a controversial thing regarding which one are more malignant or more aggressive, midgut or hindgut. So more books say that midgut are more aggressive or more malignant, so we'll go with that. And liver is the most common site of metastasis. And if liver mets are there, then carcinoid syndrome can be produced. Hindgut carcinoids, it is the same as midgut. They also drain into the portal circulation and serotonin is metabolized. If they also show liver metastasis, then there can be carcinoid syndrome which can be there. So these were the basic points regarding foregut, midgut and hindgut. Let's talk about the clinical features, how patients are going to present. So if we talk about the clinical features, the most common symptom overall of carcinoid syndrome or carcinoid tumors, is cutaneous flushing. Right, that is the most common symptom overall. But one more question which has been asked in the exam, what is the most common symptom of abdominal carcinoids? Abdominal carcinoids, the most common symptom is going to be pain. So please remember these two questions, they both are separate questions. You shouldn't get confused between the two. Carcinoid syndrome, what exactly is carcinoid syndrome? Carcinoid syndrome, I told you, is when serotonin leaks out into the systemic circulation. When serotonin is there in the systemic circulation, it can give rise to bronchospasm. It can give rise to cardiac lesions. There can be diarrhea. And there can be flushing. Again, flushing is the most common. I've already told you, flushing is the most common. Now, another controversial topic is regarding what is the order in which serotonin affects the cardiac valves and what are the conditions which it gives rise to. Well, common sense says that most of the serotonin is going to first go into the right side of the heart. And when it goes into the right side of the heart first, it is going to affect the tricuspid valve first. So, tricuspid regurgitation is more common than pulmonary regurgitation, is more common than pulmonary stenosis. That is the sequence in which it affects the heart valve. So, you have tricuspid regurgitation more common than pulmonary regurgitation, more common than pulmonary stenosis. That's what you need to remember. Now, how do we make the diagnosis? So the diagnosis is made on the basis of clinical features, plus we will carry out urinary 5-HIAA. 5-HIAA is 5-hydroxyindole acetic acid. 5-hydroxyindole acetic acid. Right? This is a metabolite of serotonin which is excreted in the urine. So this is what we measure, and this is going to hint towards a neuroendocrine tumor. Now the imaging also plays a major role in neuroendocrine tumors, and the imaging can be a serotonin receptor scintigraphy, or a somatostatin receptor scintigraphy. They help in picking up metastasis, and these scans also help in monitoring the lesions after treatment as well, right? So that is the imaging which is done. SRS is serotonin receptor scintigraphy, that can be done in these patients. Another thing which you should not get confused about, that in the blood we can measure chromogranin. In the blood, chromogranin A levels can be measured. So it is not in the urine, it is in the blood, and this question has been asked in the exam, so don't get confused regarding this. Now the management of neuroendocrine tumors, the two mainstay of treatments are surgery, and as we've discussed previously, we will try to achieve an R0 resection wherever possible. And the other one is chemotherapy. The chemotherapeutic agents used are cisplatin and 5-fluorouracil. Chemotherapy, you know, will only be used in patients where there is a malignant neuroendocrine tumor or metastatic neuroendocrine tumor. Where there is a malignant or a metastatic neuroendocrine tumor, that is where we are going to use this. And octreotide can also be used to control the symptoms. Octreotide can be used to manage the metastasis in these patients, and it helps in controlling the symptoms. Right? So before I talk about the site-specific management of carcinoid tumors, you know that this year we lost a great actor, Irfan Khan, to a neuroendocrine tumor. In my view, he was one of the most versatile actors in the film industry, and it was a sad loss, and he had a neuroendocrine tumor. So let's talk about the site-specific points which are asked in the exam. So first, let's talk about appendicular carcinoids. A lot of questions have been asked regarding appendicular carcinoids. Appendicular carcinoids are the most common, and the two things which you should remember: if there is an appendicular carcinoid which is less than 2 centimeter in size and more than 2 centimeters from the base. If it is less than 2 centimeters in size and more than 2 centimeters from the base, then a simple appendectomy is enough. And this has been asked many, many times. But if the size of the lesion is more than 2 centimeters or it is less than 2 centimeters from the base of the appendix, then we need to carry out a right hemicolectomy. So you should know these two scenarios. They've been asked many, many times in the exam. So this is just an image of a PET-CT, gallium dotatate scan with octreotide. Gastric carcinoids. Gastric carcinoids is the next one which you should know. There are 4 types of gastric carcinoids. Type 1 gastric carcinoids are the most common. Type 1 are the most common, and these are seen in elderly females. And these are associated with hypergastrinemia. They are associated with hypergastrinemia and chronic atrophic gastritis. The management of these patients, endoscopic resection can be done. So for type 1, endoscopic resection can be done. This is very important to know. Type 1 and type 2, we can do endoscopic resection. Except surgery, the indications for surgery in these patients would be that if it is a multifocal lesion, if there is infiltration of the wall, if there is infiltration of the wall of the stomach. So surgery is done if they are multifocal, that means they are more than 6 in number. This has been given in Bailey, more than 6 in number. If there's infiltration of the wall and the size is more than 1 centimeter, then also we will carry out surgery in these patients. Or if it is a recurrent neuroendocrine tumor which has recurred after endoscopic resection, that is the condition when we'll carry out surgery in these patients. Type 2 gastric neuroendocrine tumors are associated with MEN1 syndrome. They are associated with MEN1 syndrome. And these lesions also are amenable to endoscopic resection like type 1 lesions. They are also amenable to endoscopic resection like type 1 lesions. And again, if they are multifocal, if they are recurrent, or there's infiltration of the wall, then we carry out a surgery in these patients as well. Now, type 3 gastric neuroendocrine tumors are usually solitary. These are usually solitary. They are more than 2 centimeters in size usually. They present with upper GI hemorrhage. They have a high malignant potential, and there can be metastasis to the liver as well. Metastasis to the liver is also seen. And unlike the first two, type 1 and type 2, where gastrin was raised, here gastrin values are normal. So gastrin values are normal, and the management of type 3 is surgical resection has to be done. You have to carry out a gastrectomy, surgical resection has to be done. And for the liver mets, we carry out chemoembolization. For the liver mets, chemoembolization is done. Type 4 gastric neuroendocrine tumors are the most aggressive. They present as an ulcerated area. And they behave like adenocarcinomas. And they behave like adenocarcinoma of the stomach. They behave like adenocarcinoma, and aggressive management has to be done. So surgery and chemotherapy has to be done, and because these are most aggressive, that is why they have the worst prognosis as well. That is why they have the worst prognosis as well. So this was regarding neuroendocrine tumors. This brings us to the end of this module. Before we discuss the MCQs, just would like to share a lovely picture with you. This, when I was doing my fellowship in Baltimore, there was a sunflower bloom in one of the fields, and we'd gone there, and there were acres and acres of sunflowers, and a beautiful sunset setting as well. So just thought of sharing this picture just to break the monotony of a very serious topic. Let's just do a couple of MCQs and end this topic. Which vein will you encounter first before reaching the left adrenal vein to do selective venous sampling? Now, sometimes we do selective venous sampling from a particular adrenal to see whether it's a functional lesion or not. So the left adrenal vein drains into the left renal vein. So if I have to approach the adrenal vein, I have to go through the renal vein. Which one of the following mutations is not associated with pheochromocytoma? Ret proto-oncogene mutations, are associated. Yes, they are associated. The MEN2 syndromes which are there. Germline mutations of succinyl dehydrogenase B and D. Yes, I have told you, paraganglionomas, they are associated. VHL gene, yes. Von Hippel-Lindau. NF2, no. Neurofibromatosis 1, yes. Neurofibromatosis 2, no. Right? Now, a pathologist receives an appendicectomy specimen patient and is surprised to find a 1.5 centimeter carcinoid situated at the base of the appendix. Patient is healthy and otherwise has no other symptoms. What do we do? I've told you that if the tumor is less than 2 centimeters from the base, then the treatment which is to be done is a right hemicolectomy for these patients. right? For final year students, the two topics which you need to know are pheochromocytomas and carcinoid tumors. Short notes are asked from that, so you should go through them once. But predominantly, this module is important from the MCQ exam point of view. Thank you.